All right, my name is Julie Soukup, and I'm here with another episode of Take One Patient. I am so excited to be talking today with Dr. Tanya Osborne-McKenzie. She has a wealth of experience and knowledge, and is currently the CNO of MLK Community Healthcare. But a lot of education, a lot of different roles, and a lot of work has kind of gotten into where you are today. So I would love to first have you just talk a little bit about your experience and really kind of what got you to where you are at your current role now.
Okay, thank you, Julie. As you said, I'm Tanya. I am a nurse, and I started nursing about 32 years ago. I did not want to be a nurse, and in fact, my plan was to be a nurse until I figured out what I wanted to do with my life. I actually had lots of opportunities to go to school and went kicking and screaming until finally I just decided I had all the prerequisites. So I went ahead and got into the nursing program. But that was the plan, to start there, figure out what I wanted to do. When I started as a nurse at the bedside, I worked in the ICU. I took care of critically ill patients and actually started to really enjoy what I was doing. I also started doing some other things. I did adjunct faculty, teaching folks in clinical space. I also started teaching classes at the hospital. Um, um, ACLS, BLS, different types of classes to my peers. Um, and really just started really enjoying the work that I did. I continued at the bedside. I go to work. Sometimes, you go to work and you look at people and you're thinking, I wouldn't do that. Oh, I shouldn't do that. So I actually talked to my mom who lived with me at the time, and I would go home and I would complain, well, they did this, they did that. And what she told me was, Tanya, you need to be like Gandhi. You need to be the change you want to be, or you need to be quiet. And so that's what really made me decide, instead of complaining, what can I do? And I applied for a director position for my first real formal leadership role. And when I applied for that position, and I didn't get it. Right? I applied for a director position. I did not get it. I felt like I really should have. I felt like I really should have got it. And so after you go through feeling sorry for yourself, I went back to a friend and colleague of mine who was on the interview panel, and I asked her what happened, and she said, "We really thought you would do a great job, but you know what? You behaved like what you were, is a really strong clinician, but you didn't. You looked as if you had not seen the job description at all." So it's like, oh, okay. So I went back to my life. I'd started going back to school to get my baccalaureate degree. And about 18 months later, another director position opened up. And at that point, one of the floors that I was teaching on, their leadership, the assistant nurses there, the assistant head nurses there, their educator, their case manager, they called me up to meet with them. So I went up to meet with them, and they asked me if I would apply for the director job on that floor. And part of it, still feeling a little disappointed that I didn't get the first opportunity that I applied for, but also what I told them was, and this was factual, it was a joint replacement spine and post-op floor. And I said, I don't know orthopedics. I worked critical care. And Lourdes, who was the educator, she told me, she said, we have orthopedic nurses. We need a leader.
Yeah.
And between what I was told by my friend and colleague before and what Lourdes just told me there, and finally I had this epiphany that leadership that's a specialty in and of itself. And I was looking at it all wrong. And so that's when I really started to understand leadership is a specialty, and there's a certain set of skills that you have to be a good leader.
Yeah.
And so with that, I did apply for that position. I was awarded that position. And so I was the director. So I went from literally that Friday, I had an open heart surgical patient I was taking care of. And that Monday, I was now the director of what was really a joint spine and post-op floor. I missed some steps in there. So I was never, I did relief charge, but I was never a formal charge nurse. I was not an assistant manager or manager. I went from a staff nurse to a director. So there were some gaps in my education, right?
Yeah.
There were some gaps there in my knowledge. And so I continued my education. So I finished my baccalaureate degree, and then I went to get my master's. And I decided I wanted to honor nursing and wanted to make sure I obtained the master's in nursing. But I also recognized at the time that nurses, one of the things that we could be a little stronger in is being able to make a business case for quality.
Yeah.
And so I wanted to be able to understand the business part of it. So I also got a master's in business administration. So I earned a MBA as well. And then one is I'm kind of a nerd. I just enjoy school, but also wanted to ensure that I really understood my job and the role, and decided I would go back to school to get a doctorate. And at the time, I was interested in getting a PhD. But the PhD is really about research, and the work that I do is in the practice arena. And so spoke to some friends and colleagues, and they talked to me about doctorate in nursing practice, a DNP. And that focus is really around putting the research into practice, into the practice environment. So that was really interesting to me. And the University of San Francisco has an executive leadership doctorate in nursing practice degree. And so that's actually where I went, and that's what I earned as my executive leadership DNP. Some of the benefits of that, because I get a lot of times people say, well, what is a DNP and what do you do? What do you learn? But some of the things besides, there's foundational knowledge, right, in executive leadership. There's also finance at a higher level, and lots of work around change management, because if you're going to bring that research into practice, you actually have to understand the steps in change management. And especially, right, we want to use the evidence, the science, that we want to not just conjecture and this is what I think, but actually here is really the evidence that shows if you do this, you will get the outcomes that you want. So after I graduated with my DNP, I switched jobs because I just really wanted to see if I could replicate what I had done at the first hospital to the next hospital. I felt like I was successful there. And then there was an opportunity at Barrow Neurological Institute, which, is world famous. And so I went to work there at St. Joseph's to be the senior director at Barrow Neurological Institute, senior director of their neuroscience nursing. Yeah. That was really a great place to be. I love Barrow, cannot ever say enough of good things about the level of caring for the patient, as well as the level of science that they want to bring to that area, the innovation that we have there. It was a fascinating place. We went through, as soon as I got there, I think 5 months later, we went through COVID. Right? Yeah. And so, while I was there, I shifted, and I was very honored to be given the Assistant Chief Nursing Officer position for St. Joseph's Hospital, which Barrow is a part of. And then while I was there, I really thought a lot about the fact that I've been in leadership for a long time, and I always thought I was happy as a director, but then I realized that, there was a little bit of imposter syndromes of sort of like, how did someone who started this journey as an ADN grad, right, and how can I imagine myself being a chief nursing officer someplace? But then at that point, I started to realize I could do it, and not only could I do it, but I should do it. Right. And so really wasn't actively looking for a role. However, and that's the way life is, right? What happened was this role here, I knew someone who had been at this hospital before, and had talked to me about the hospital and what they were doing at Martin Luther King Community Hospital here in LA. Mm-hmm. And where I'm at, this community, there's a desert of physicians. We could actually use at least 1,200 more physicians in this area, in this community, which we don't have. And this is MLKCH is a private public partnership, and the goal is to care for the patients in this underserved community. Yeah. Dr. Batchelor, who is our CEO here, very much committed to providing the same level of care here in the safety net hospital in this community that people would find in any other hospital in a more affluent neighborhood. And to that end, we are working on achieving Magnet, which is a nursing excellence that some people may not expect to see in a hospital like this. We've recently just received the Joint Commission's certification for advanced diabetes care, which less than 70 hospitals, not safety net hospitals, but less than 70 hospitals in the country have that designation. So we are very much on a journey to provide excellent care to the folks in this community, people you would think would need it the most. We've just started a street medicine program. So we go out on the streets to take care of patients who are unhoused. So this is one of the things some folks, it's a relatively small hospital. It's a 131 bed hospital. So people, I've had some people say, oh my gosh, you're moving from this big hospital to this smaller hospital. And I like to tell people it's a smaller hospital, but it's a really big job. It is a really big job.
Yeah. Well, and I mean, especially now that you're starting to be able to have a different perspective from, even Barrow to a situation such as that, and bringing that kind of wealth of knowledge of different ways to start implementing and making changes in places, a hospital that maybe didn't really have that kind of focus before.
Mm-hmm.
So you've really talked when we had spoken before, and I thought it was really, spot on as far as for other people that are really looking at, okay, I might not have a chief nursing officer role. I was a director or things along those lines, but I do want to start having an impact. I do want to implement something. I want to try something out, especially for, we had met you with working with medical memory with St. Joe's, and which is that HIPAA compliant app for video recording patients. So even we have a lot of directors that are like, okay, I want to do this, or I want to do something even different. You kind of talked about some of the steps that you go through when looking at trying to implement something. Talk a little bit more about that and what you've learned, even for someone that's a director that wanted to kind of start doing some of those things, or nursing wanting to start trying out something new.
Right. So one of the things when, in terms of my job, and this is when I was a director as well as now, because I did get my doctorate while I was a director. I've had it for about 10 years now. But one of the things that we focused on, that we really focused on with that DNP is pulling that pulling that research into the workplace. And it's some basic, a basic process for improving or making changes is really first understanding the reason for the change. Really, why is it I'm going to do this, but the so what? I'll give you an example since you did bring up medical memory. When I was at Barrow, we decided that, we know that there's a lot of research that talks about the patient experience and how it is directly related to patient outcomes, right? So if I improve the patient's experience, then I can improve the patient outcomes. And if you're a nurse, as a nurse, we know that our job is literally, and I think it's the ANA policy statement actually says that nursing is the diagnosis and treatment of the human response to actual or potential healthcare problems or needs. So if our job as nurses is to diagnose and then treat the human response to any healthcare problems or needs, and we want to make sure that we do that, then we need to use the science. And if the science then says that patient experience is directly related to outcomes, if we improve the patient experience, we improve their outcomes, then we actually have to figure out how are we going to do that. Yeah. So starting with what's our reason for action? Our reason for action is to improve the patient experience so that we can have better outcomes. We can improve our patient outcomes, which is something every place wants to do. Of course, we wanted to do that at Barrow. Right. And then you look at what your current state is and what your target state is. In this case, it's easy because we have HCAHPS scores, which most hospitals will look at. So we targeted one part of our HCAHPS scores, which was RN communication. So we wanted to improve the nurses' communication with the patients, because if we could improve the nursing communication with the patients, so if you think of just building relationships with the patients feel more comfortable telling the nurses or their physicians what is happening with them, what their needs are. They're also more open to listening to us and helping and collaborating with us to help improve their care, right? So we look at what's our reason for action, we look at our current state, and then what our target state was. So in this case, we looked at what our current state was for overall, our composite percentile, how people wanted, would they want to come back? Would they recommend being at Barrow, recommend being on those units? And then we looked at our current state of communication with nurses in general specifically for our HCAP scores for each of the units. So then you look at the gaps. What are the gaps? Well, one of the gaps was that it was hard to time when the families for those patients would be there and when the nurse would be in the room, or when the families were there and the doctors would be there. Another one of the gaps is that we knew that people forget about 40, they remember about 40% of what you tell them in the hospital, right? You're not at home, you're sleep deprived, you're actually in the hospital because you're sick and you're stressed. You don't remember a lot of what's going on. So some of the science, we looked at what was happening with the physicians who were currently using medical memory. And we looked at the data, and the physicians that were using medical memory, their individual patient experience scores were vastly higher than what we saw with the physicians who weren't using medical memory. So we believe that if we used medical memory for nursing, that we would get that same result.
Yeah.
So we did a PDSA, which basically was we started to register the patients who were on those on our units in Barrow. We would register them with medical memory, and then the expectation was that the nurses would every day would just give one small, 1 minute medical memory update. So they would do one video. Often they'd be in the room with the patient. They'd have the medical memory camera on the patient, and they would say, I'm making this up, but something like, this is your mother today. She slept well last night. Today she's going to have a CT scan. The doctor will be in later to give her the results. Just really brief. Right. Sometimes the message was something like, I remember this one where this one patient, that they changed the time of the patient's surgery. And the nurse just put up a video showing that patient and saying that, your mother's time for surgery was changed. It's going to be an hour and a half earlier, right? That was it. But that was one of the videos that we received the most input about, because the family was so grateful just to get that information.
Yeah.
The interesting thing about doing this was, I told you I started working at Barrow at St. Joseph's in 2020. Yeah. I started working 5 months before the pandemic started. So the interesting thing about this, and this is why it is so important to let science and use a strong change management process to guide what you do, because right as we started this, COVID happened. And if you remember when that first started, we didn't let anybody in the hospital, no one. Yeah. So if you look nationally, most everybody's scores for communication dropped. In this case, and the remarkable thing about this was our scores actually went up. Yeah. So I know specifically for those med-surg tele floors where we started with the baseline in neurotelemetry, our average was, both communication with nurses, our average was 16%, and it actually went up to 45% by the end of the year. So using the science, understanding where the gaps are, having a strong implementation process, those are the kind of things with change management that really helps a great deal. And it's something that we definitely learned during that time. But a lot of that is what I learned from the experience, and also just, and from school, to be honest.
Yeah. Well, and I think it breaks it down, into, just as you said, starting with the patient, having your why is great. Great, this is why I want to do it. But taking that, okay, well, what is the business case? And hospitals are still a business. People don't want to be like, oh man, but it still is, well, what is the value it's going to provide? And what is the financial benefits going to provide? And if you're saying, patient-centered and patient-focused with that, it's easy to kind of build the business back versus just, oh, it's impulse and this would be great. And so leveraging HCAPs or leveraging, patients' readmissions or outcomes or anything like that, what's the business there? And I think those kind of even backwards steps I'm almost visualizing really helps it support more of that leadership as a practice of, well, what's the why even try it? Not just for the patient, but why to try it for a hospital.
Exactly. There's a book that I read. It's called "So Good They Can't Ignore You," And the reason that I think of that book, I think about back when I first started nursing, and I absolutely did not want to be a nurse. And so what he, and I can't remember the author's name, but what he posits is that one of the things that we have right now, everybody wants to have a job that they are passionate about. And people feel like they have to have a job that they're passionate about. And, for example, my husband, if he had a job that he was passionate about, he would be a professional golfer. He's passionate about golfer. He's not great at golfing, right?
Yeah.
So we would be hungry. But
Yeah.
what this author posits is that if you start what work you're in right now, whatever work you're in, the more you learn about it, the more you get interested in it. The more you learn about it, the more you become an expert in that area, and the more people start to ask you about it and ask you to offer them your expertise, the more you actually start to really enjoy the work, which frankly is what I believe happened with me with nursing. Now, I read that book like 20 years after I became a nurse,
Yeah.
but I really do think that there's a lot to that philosophy. And so I say that because with nursing leadership and understanding that that truly is a specialty, the more you learn and the more competent and proficient you become at those leadership skills, the more you enjoy that work.
Right. Right. Well, and as you kind of even said, is, for even like there's tons of books and so much data that's available to kind of even start becoming an expert and just learning more, even in your specialty, to help make those kind of process improvements or implementation improvements to like that are available. How do you when you are like we can keep using medical memory as an example or different things. How do you go about, okay, so now you have the business case, now you have the data, you're wanting to try something new, especially like video recording, and that's how do you go about when people then are resistant, or nurses are resistant, or even the other way, leadership was more resistant. How do you break down those barriers, knowing the research, knowing the data, knowing what you're trying to do? Great, we got it all buttoned up, but how do you handle those type of situations?
And you will get resistance. You know that even with any type of change management, any change, you're going to get resistance. I mean, it can be the best. It can be personal level, right? I need to lose weight. I need to have a healthier lifestyle. I know that's what I want. It's still hard, so there's always going to be resistance, right? So but just like with dieting, where I understand why I want to do it and I own it, that's the same thing with any kind of change, is that you can't have that change can't be in a vacuum. It can't just be me in my office. This is what we're going to do, and then go out and do the change. Just like I owned the diet plan, my healthy lifestyle plan, you have to get the team to own the change process,
Right.
because then when it gets hard, the team owns it, we can still work our way through it. And so what I mean by that is, for example, with making the business case for quality. So if I'm looking for funding, I need to be able to make the business case with the finance folks so they own the change. I'm actually doing a change here right now that I want. And that was the first thing that I did, was I went to the finance folks and explained what I wanted, right? My reason for action,
Yeah.
like why am I doing it? Where we're at right now, where we'd like to be, right? And then where my gaps are. And so, this is one of the things that I think we can close the gap on. And so once I'm able to partner with the CFO and his team, then I also am talking to my nurse leaders. We bring in some staff nurses as well, because we need everybody to own this process. So we kind of talk about the why we want to do this and hear what they have to say. And then I can bring up, well, again, here is what here, and they can help with, here's the why, the reason for action. I can give them the data for the current state. And here's where we'd like to be. They all help with gaps. Here's a process. I've never had a position where when I bring in the team to bring the gaps, if we've already started looking at the data, or even when the folks, when the team starts to look at the evidence, look at data, if we're looking for evidence-based practice, then we'll get to what we all want, right? And we all own it. But you have to bring those folks in early. You can't go to somebody, think about that, right? My husband comes to me and says, Tanya, you need to lose weight.
Yeah.
A whole different story than I say, oh, I need to lose weight, right?
Yeah.
It's the same kind of thing.
Yeah.
Right.
So for when even like, okay, you're going to nursing leaders or and someone's like, well, I I don't think this is going to work. Or I don't think, I mean, I guess that's what you're saying is that's why you have the data to support it. And like,
Yes.
this is what we're testing. This is
Yes.
where it's shown before.
Yeah.
Like, but even when you still get people like, well, there's another way, or we couldn't do it. I mean, how do you kind of get them even to be on board to own it, or say, well, let's at least try it, or how do you kind of go about that with even those strugglers or ones that say no to
So
everything?
usually what we'll do is, no, and because you will always have those. And so when you look at the gaps, there's usually lots of gaps, right? But we have to prioritize what we're going to do first. And so it doesn't mean that what they're recommending is any more correct than what you're recommending. So what we usually do is we list the gaps, and we do a PDSA, right? Process. We look at we do a cycle of change, and I think of it really. I actually I use this as an example all the time. I think about the iPhone, right? Because what the iPhone did for us, and the reason we're on what is an iPhone 13 now? They gave us an iPhone that was good enough, and then we all said, we want this, we want that. Then they go back, they give us something that's better. Here's our iPhone 2. So that's why it's always a cycle. It's not, it's not here's the change, boom, we're done. It's always a cycle. And so sometimes in healthcare, especially, we want the solution right away. And what I remind people is it's a cycle. So we start with this, we get incrementally better, right? Now let's add this next part and get incrementally better, because we're always trying. And that's why that, perfection versus excellence. If you shoot for excellence, you can continue to get improvement. If you shoot for only perfection, people tend to get really frustrated, because how often can you get to perfection every day?
Right. And I think that goes back to what you were saying earlier, is it truly is a practice. And as you're even describing that is, okay, great. This was phase 1. Now let's go back. Let's phase 2. Let's go back. Like, let's continue to strengthen and improve. But it's a practice. We're not going to always just have it like immediately. Like, this is the magic bullet. Because if we found the magic bullet, that would be easier.
And it's like everything in healthcare, right? Everything in healthcare changes, right? We hope it's always improving. It's always evolving. People are not stagnant, so they are going to continue to change. So we have to continue to evolve and change as well.
Right. No, absolutely. Well, thank you for all of your intellect and all of your experience, especially as you helped, with medical memory, kind of getting those things through. But I think you bring up kind of, again, back to those 3 things of, making a business case, speaking to the why, and then really keeping that patient at the center as you're kind of planning things out. And I think that is great advice for anyone looking at implementing, well, not even necessarily in a hospital, just in anything.
Right. This is true.
Examples. And I know like a lot of people kind of thinking about that, and those simple steps is, okay, great. Now I have kind of a plan of action, if you will, to kind of help support change in those things. So I really appreciate you taking the time to be on our call today. Is there anything kind of you want to add as far as the last nugget?
I don't think so. I think you kind of wrapped it up for me, but I appreciate having the opportunity to be able to present some of my thoughts. So thank you for that.
Yeah, absolutely. So great. Well, thanks again, and have a good rest of your day.
Thanks, you too.